Hello, everybody. Thank you so much for joining us. My name is Lindsay Brooks. I am a licensed veterinary technician, and I'm the clinical application specialist for Mindray North America. We'll be talking about some ventilation modes that are commonly used in veterinary medicine, but more specifically, the ones that can be found on Mindray anesthesia machines. And these are my pets. They're very cute. And we have a cute little thing. We have all of these ventilation modes that are helping to support our little baby friend right there. So ventilation modes in general. So the reason that we'll put a patient on a ventilator is to make sure that our respiratory system is being properly supported during anesthesia. Humans obviously can be put on a type of ventilation while they're awake, such as CPAP. My dad has a CPAP machine for his sleep apnea. But in general, we are really only putting patients on ventilators in veterinary medicine when they're anesthetized. So there's kind of a spectrum of anesthesia ventilation for our patients, and it's kind of a ratio of how much work is the patient doing versus how much work is the machine doing. So the different levels are going to be spontaneous breathing, where the patient is doing a lot of work. The patient is determining the respiration rate, the size of the breath as well. We have supported breathing, which similarly we have our spontaneous, which is way over here. That's the patient doing all of their own work. We have supported breathing, which is the next down on the spectrum, where the patient is still doing a considerable amount of work versus the machine. We have synchronized breathing, which can also be called assisted. And at that point, the patient and the machine kind of do maybe similar amounts of work. And then we get into the mandatory level right there. So we went from happy to not so happy here. The lowest that we go just generally in veterinary medicine, just for your general referral practices and specialty hospitals, is going to be right here, this line. And this is volume control and pressure control. And these are some of the basic ventilation modes that we find on a lot of ventilators. And they are mandatory controlled breathing. And that in that case, the patient no longer has a respiratory drive, or should not any longer have a respiratory drive. As we move on down, we get more and more involved. We end up with, BiPAP, APRV, high frequency oscillation, and ECMO. So at this point, the patient is actually doing no work. ECMO is essentially bypass. Oscillation is, it's expressed in hertz. It's not even expressed in respiratory rate. So we keep it up higher over here. And so I'm going to be covering the modes that are most commonly found on veterinary ventilators in general, and like I said, the Mindray ventilators that we have. So a little bit of background on how the ventilators work. We have three different groups that represent different types of patient control versus machine control. So our group one, our trigger right here, which is going to be the beginning of our inspiratory, expiratory period. Our trigger is mandatory and our cycle is mandatory. So what that means is the machine is going to determine when the breath begins, so when inspiration begins, as well as when exhalation begins. So some examples of these will be our volume control and our pressure control. These are good for patients that are very sick or maybe have a paralytic on board. Our next group, group two, is we have a spontaneous trigger and a mandatory cycle. So the spontaneous trigger means that the patient gets to decide when they take a breath in. If they have, any kind of respiratory drive and they're ready to take a breath, their body is telling them to. That spontaneous trigger is going to let them take a breath when they want to, but that mandatory cycle is going to be the machine saying, all right, you can take a breath whenever you want, but I'm going to decide how long your breath is, how deep it is, what kind of airway pressure you're reaching, what kind of tidal volume you reach. And so those are going to be the synchronized intermittent mandatory ventilation mode, which we'll get to. That is a mouthful, I know, and assist control, which not all of our machines have this. Actually, I don't think any of our machines have assist control, but it is a spontaneous trigger with a mandatory cycle. And then our group 3 is probably, these are going to be more intelligent ventilation modes. So you have a spontaneous trigger as well as a spontaneous cycle. So your patient decides when they breathe in as well as when they breathe out. The machine is just there to make them take better breaths, help them take bigger breaths if they, if that's something that they need to be doing. So those modes are going to be modes such as pressure support ventilation and volume support ventilation. Oh, there's our cute little illustration again. So the anesthesia machines that Mindray sells has these types of ventilation modes. So we have volume controlled ventilation, pressure controlled ventilation, pressure support ventilation, that synchronized intermittent mandatory ventilation again. And there's actually 2 different types. There's SIMV PC for pressure control and SIMV VC for volume control. When I explain those ventilation modes, the PC and the VC will make a little bit more sense. And then lastly, we have our volume support mode. And that one is actually only on our Vita 5, and we'll introduce that in a little bit. So starting out with our mandatory ventilation modes, we have volume control. So we all know our tidal volume is our inspiratory flow rate over the period of time of our respiratory cycle. So in VCV, we have a preset amount of volume delivered at a preset time, at a preset rate. So your airway pressure may vary just depending on the size of your patient, the compliance of their lungs and thorax. And when the airway pressure reaches the pressure limit that you've set during the inspiratory phase, that pressure will be maintained at that level. So it might reach a higher level, but it'll drop back down to a pressure limit. So we see here we have our tidal volume determined. We want 500 mils. So that's going to be our flow of air into our patient over the amount of time that they are inspiring. So we have our inspiratory time and our expiratory time. So we see that as our oxygen or our air flows into our patient at 2 liters per minute over this inspiratory time, our airway pressure is slowly rising up to our peak airway pressure, our P peak. And then as our patient exhales, that airway pressure slowly decreases back down to our baseline. Whether our baseline is 0 or if we have some Peep going, and I'll explain Peep here in just a second. And you can see our airflow, it runs at a constant rate until the patient, until the machine lets the patient exhale. We have a negative flow as that air is flowing out of the patient, and then it slows down, or it speeds up to 0. And then it starts all over again. So we know that in general, our tidal volume for dogs and cats is going to be a range of 8 to 15 mils per kg. Cats are on the lower end. Dogs, depending on the conformation of that dog, they might be on the lower end or maybe on the higher end if you have a deep-chested kiddo such as a greyhound, borzoi, galgos, etc. Now our tidal volume ranges on our ventilators. Our Watto machine can go down to 20 mils of tidal volume, and our Vita 5 can actually go down to 5 mils of tidal volume. So that's great for your smaller patients. You know, your little kitten with a congenital diaphragmatic hernia. If you have a patient that's half a kilogram, a 10 mil per kg tidal volume of that half kilogram patient is 5 mils. So you're going to be able to more safely and more confidently ventilate smaller patients on this Vita 5. Next, we have our rate and our I to E ratio. So obviously we know that our respiration rate is how many breaths you're taking per minute. But when we break that down a little bit further, it tells us what is our, how long is each breath cycle. So each breath cycle is inspiratory time plus expiratory time. So this says 12, but we're going to work with a slightly better rounder number, like a rate of 15. So if I have a patient with a respiratory rate of 15, each one of their breaths is going to last 4 seconds long. And depending on how we adjust this I to E ratio, this inspiratory time compared to expiratory time ratio, that'll determine how much of the time the patient is breathing in versus breathing out. Now with an I to E ratio of 1 to 2 at a rate of 15. So each breath is 4 seconds, 1 part versus 2 parts. You'll have an inspiratory time of 1 1/3 second and an expiratory time of 2 2/3 seconds. Now, if your patient is particularly ill and you feel that you need to have an inverse ratio of and I'll show you actually here, inverse ratio ventilation. That's where their inspiratory time is actually longer than their expiratory time. So their lungs are filling for longer. They're able to expand their lungs a little bit more. They have a higher mean airway pressure, etc. So you can adjust this I to E ratio just depending on the needs of your patient. So we also have a setting that it is called T-pause. And so T-pause is expressed as a percentage of the entire respiratory cycle. So a 25% T-pause is going to be a pause of 25% of the entire breath cycle. So if I'm at this respiratory rate of 15 and each inspiratory expiratory cycle takes 4 seconds, T-pause is going to be 1 second. And that's actually going to be essentially what this does is it's a breath hold at the end of the inspiratory cycle. So your patient is receiving this, there's this constant rate of airflow to your patient, and then it's paused for a moment. So we have our airway pressure is coming up, and then we pause for a second. We have our peak airway pressure, but when we turn off this flow to 0, it goes down a little bit. And then it holds at this plateau pressure. What this does is it will increase your mean airway pressure. It's going to help your alveoli, your distal alveoli open up a little bit more. And then after they hold their breath for just a second, they exhale as normal. So right here, we don't have a flow of air because both of our valves are closed. Both our inspiratory valve, it's open here, they're both closed here, and then our expiratory valve opens, our patient exhales, and then gets ready for its next breath. And this percentage can be between 5 and 60%. So if we did 60% of a 4 second long breath cycle, that's let's see, it's over half. You know what? Let's say it's a 5 second breath cycle. That's easier for me. So let's say you're at a respiratory rate of 12. Each breath is, each inspiratory, expiratory cycle is 5 seconds long. If you have a 60% T-pause, that would be a breath hold of 3 seconds. So your patient breathes in for a short time, holds their breath for 3 seconds, and then exhales. That might not be clinically appropriate for most patients, obviously. So again, with VCV, you can set a pressure limit. So as we have this constant flow, our airway pressure climbs and climbs, and we don't want it to get to an inappropriate level. So we can set our pressure limit, which is where the expiratory valve will automatically open up and release the airway pressure for your patient. Now, when we have a pause, oh, and you can see that right here. So as our airway pressure climbs, if our pressure limit is set to something a little bit lower than our peak airway pressure has been reaching, it'll automatically just truncate the additional airway pressure. It'll release it so that your patient doesn't go into some scary territory there. Now we can also set a PEEP. PEEP is a positive end expiratory pressure, and I'll explain it a little bit more on the next slide. But essentially, it just keeps the airway open a little bit more. It's a working constant airway pressure, so that instead of your patient having to inflate their lungs all the way from 0 to 18, they're just going from 5 to 18. I like to kind of give the example of if you're running down some stairs and then you say, oh no, I forgot something upstairs, I have to go back upstairs. Would you rather remember that 3 steps from the bottom, or once you already get to the bottom? I'd rather remember it 3 steps from the bottom. So PEEP, it kind of reduces the distance that the lungs have to travel to open back up. So like I said, it's additional alveolar pressure that exists at the end of expiration. So there's 2 types. There's applied PEEP, which is us putting 3 to 5 centimeters of water as our PEEP setting, just to help our patient be a little more comfortable as they're expanding their lungs, have less volume to travel. And then there's auto PEEP, and auto PEEP can also be called intrinsic PEEP. And this will happen by accident. This is happening without us actively trying to have PEEP. So this can result from insufficient expiratory time. Your patient hasn't had the chance to breathe out all the way before they're already breathing their next breath. It can also result from a limitation on expiratory flow. So there's just not enough bandwidth for all of that air to get out of the lungs before we're coming to our next breath. So a small AT tube, COPD, respiratory circuit issues like obstructed expiratory filters. And then it can also result from dynamic hyperinflation. So this is where your patient's baseline, it's a climbing baseline. So your patient exhales and they're not at 0, and they're not at 2, and they're not at 4. They're slowly developing a higher and higher end expiratory pressure baseline. And so this can cause reduced cardiac output, hypotension, barotrauma as well. And it can cause ineffective ventilator triggering, because the ventilator no longer is understanding that, this patient is reaching this baseline in the first place. It's just continuing to deliver what you've told it to deliver. And it doesn't know that the patient's tidal volume is growing and growing and growing, or their airway pressure is getting lower and lower. So it's obviously not a good thing. So PEEP is not actually a ventilation mode. It's just an increase in our baseline pressure. It can be added to any support mode. And there's a lot of doctors who just like to have, a PEEP of 3, just all the time. So some indications to apply Peep, extrinsic Peep, would be to get rid of the auto Peep. It's like, oh, well, oops, my patient has intrinsic Peep. Well, let's make sure that it's something that we wanted to do. So let's just go ahead and make sure that we are keeping that airway open, since they're not able to get all the air out of their lungs in the first place. It can also help to decrease hypoxemia from different types of systemic diseases. And it can also help to maintain or increase the functional residual capacity of the lungs, especially during something like thoracic surgery, where the lungs are kind of, they're out in the world, and they're no longer constrained by a chest anymore. What's going on? They don't know what's going on. Some advantages: you get a higher PaO2. You can help to increase your lung compliance, and it decreases the work of breathing. Like I said, do you want to forget something upstairs? Actually, I should be saying downstairs. Do you want to forget something downstairs halfway up the stairwell, or once you're already all the way up the stairwell? No, you don't want. You want to decrease your work. Some disadvantages, though: it can increase your mean pleural pressure, and as well, and which causes its own set of issues with intracranial pressure, pulmonary vascular resistance. It can decrease your venous return from having that elevated additional mean airway pressure, and it can increase the incidence of barotrauma if your patient can't handle a high level of airway pressure in the first place. Adding additional airway pressure might not be the best idea. So some of the benefits and drawbacks of volume controlled ventilation: you get an accurate airflow rate, you have a constant tidal volume, regardless of the compliance and the resistance of the lungs and the thorax on, say, obese patients. And you end up with a stable blood gas and oxygenation. However, when you're giving a constant tidal volume, that may result in hypo or hyperventilation. That might not be what the patient needs just metabolically. If a patient has spontaneous breathing, if they still have a respiratory drive, it can cause barotrauma as they're trying to breathe around the ventilator. You can't compensate for leakage in your tube, your hoses, your ET tube, or in your respiratory circuit. So you might lose some of your volume if there's a leak somewhere. Your patient might experience air hunger, which is, again, a hypoventilation type of problem, where your patient is like, I'm not getting air fast enough, I'm going to breathe around the ventilator, I'm doing additional work, I'm metabolizing faster because I'm working harder, and my oxygen consumption is increasing, which becomes like it becomes a cycle. It becomes a catch-22. Your patient is working harder to get more air, but they're having to fight the ventilator to get more air, which makes them work harder, et cetera, et cetera. Then if your inspiratory flow rate is too high, your air delivery time is shortened, your peak pressure gets too high, you end up with lung barotrauma and alveolar shear injury. So you want to make sure that your breaths are nice and long enough, but short enough at the same time, but not too short. And then again, you can end up with asynchronous breathing. So your patient can try to take a breath, and then the machine will go, oh, well, I'm still delivering this full tidal volume, whether or not your patient wants it. So you can end up with, again, lung damage there, lung injury there. Next, on to pressure control ventilation. So again, this is a controlled ventilation mode. In this case, your airway pressure rises quickly to a supportive pressure, delta pressure limit within a certain amount of time, and then it's maintained at that airway pressure until the patient breathes out. So in our volume control mode, as you can see, airway pressure is slowly rising, So your patient is taking a nice long breath in and then breathing out. And then a nice long breath in and then breathing out. In pressure control ventilation, your patient is breathing in quickly, holding their breath, and then exhaling. So during the inspiratory phase, if the delivered tidal volume exceeds the upper alarm limit, the system will automatically switch to expiratory phase immediately and release. The same way, if your patient reaches that airway pressure limit, the exhalation valve immediately opens so that your patient will not go above that pressure limit. It's the same with this tidal volume limit. So in PCV, compared to VCV, there is no T-pause segment because the entire inspiration stage is breath holding, and you'll kind of get a better idea of that when we look at our flow time and pressure time waveforms. So like we saw with volume control, the flow was constant, so it immediately reached a certain rate and it held at that rate. In pressure control, our flow is very high for a very short time, which is our T slope. It's just our inspiratory time, trying to get up to that set airway pressure, the pressure inspired. So our airway pressure rises quickly and holds until we exhale. Our airflow is delivered quickly, and then it slows down as it comes back down. Again, we have our rate, we have our I to E ratio. Your inspiratory pressure range is going to be between 5 and 60 centimeters of water. Obviously, we don't usually go over 20. So 60 is, that's essentially when you set something to 60, you're essentially closing the pop-off valve. Pardon me. So again, our T slope is the amount of time, and it's expressed in seconds, the amount of time that it takes for us to reach our inspiratory pressure. So this right here is our T slope, our slope time. And that's expressed by this one right here as well. You can see here, there's also Peep if you want it. So some of the benefits for pressure controlled ventilation, the airflow is delivered in a similar way to physiologic inspiratory flow. The inspiratory flow rate can automatically adapt to the needs of the patient. So your patient is less likely to have those air hunger signs and try to breathe around the ventilator. You end up with a constant airway pressure, and so you don't run the risk of an excessive peak pressure like you might in volume control. There's no inspiratory pause, and the low peak pressure, those lead to a higher average airway pressure, which can help improve oxygenation. With pressure control ventilation, the machine is going to deliver air at a rate that it needs to in order to reach that airway pressure. So in this case, it can compensate for a leak in the system. Normally it would reduce tidal volume, but since our goal is pressure, it's just going to keep delivering until we reach that pressure. So it's much more compensatory for leaks. And since the initial flow rate is high, it can help redistribute the gas in the lungs and thus improve oxygenation, getting the better gas exchange from your endotracheal tube all the way down to those most distal alveoli. With this, though, you do have to keep an eye on what kind of actual tidal volumes you're reaching. You don't want to, end up with some dynamic hyperinflation. Your blood gases can tend to vary, so you'll have to do, additional blood gas checks. And if lung compliance is decreased, or if there's additional airway resistance, your patient's oxygenation may end up requiring more ventilation, but your tidal volume might end up going down because the patient just cannot accommodate a bigger breath. And when lung compliance, conversely, if lung compliance increases or airway pressure decreases, your patient may end up with a lower need for oxygenation because their lung condition has improved, but tidal volume may still end up increasing because of that additional lung compliance, and they may end up hyperventilated. So in this case, you may end up hypoventilating, and in this case, you may end up hyperventilating. So just, things to keep in mind, and that's why it's important to have a savvy nurse or anesthetist running your ventilator. Now, pressure support ventilation is what we call an intelligent ventilation mode. It is a supported breathing mode. So with our supported modes, that we have if we consider back to our three little groups, PSV is actually the synchronized level. So you have a spontaneous cycle, a spontaneous trigger and a spontaneous cycle. So it's patient triggered, like I said, the pressure is limited and we're flow cycled with our breath. So our tidal volume is going to depend on our patient's airway pressure as well as their breathing effort. So the airway pressure, for instance, thinking back with our pressure control ventilation, again, our airway pressure increases quickly until the flow rate reaches a certain level, and then the patient can exhale comfortably. So we have a few new features on here that we hadn't seen before, and we'll go through all of those. A few new settings. So here we have our delta P support. So the delta is just on top of what your patient is doing on their own. So your patient takes their own breath, and it's triggered right here by a drop in airway pressure, or it's triggered right here by an increase in airflow. And at that time, that's when your you can adjust your flow trigger here. So if you want your patient to be taking a more active breath versus just taking little shallow breaths, you can adjust your flow trigger to be more or less sensitive. So when your patient takes a breath, we have a T slope, the time of inspiration. So we have half a second. So it takes half a second for that flow to come up and reach this delta P support, this difference in pressure support right here that we've just determined right here. And much like our pressure control ventilation, your patient's breath is going to be held for a little while and then exhaled. So the next slide, I believe, is actually going to show us when we exhale. But there we go. We have our delta P support. So if we have Peep applied, if we have Peep turned on, that delta P support is going to be anything above Peep. Now, if your patient should go apneic and we need some backup ventilation to reach our minimum rate there, this will apply 15 centimeters of water in this case. Or you might want to have maybe a higher amount of airway pressure for your backup ventilation. These are just going to be mandatory breaths that are only given when your patient is not reaching this minimum respiration rate. So as you can see, we have our trigger described here. It's just the change in flow rate from, the baseline that we have flowing to our patient to begin with. And this can be anywhere from half a liter to 15 liters per minute. in terms of our flow rate trigger. We can also set your flow rate trigger, I'm sorry, not flow rate trigger, your trigger in general to be a pressure change. So if you want it to be -3 centimeters of water, or if you just want to make sure that you're only ventilating your patient when they're trying to take a nice big breath, you know, you make it a little less sensitive and you dial down that airway pressure. You make sure that your patient is taking a nice deep breath before you give them that additional ventilation, because if this is too sensitive, you'll end up hyperventilating them, because we don't want every single, you know, puny breath to be supported. We only want a reasonable rate of breaths to be supported. So you can see there's our trigger right there for our airway pressure, and there's our trigger right here for our airflow. Okay, so here we've reached this expiratory percentage. So this is a percentage of our maximum flow rate, our peak flow, P flow right here, peak flow. So when, all right, bear with me. So your patient has taken a breath. The machine is giving you a high rate of air to reach this airway pressure that we want. And as the flow is coming back down, just depending on, you know, how fast it was in the first place, once it reaches 25%, so this number, once it reaches this percentage of that peak flow rate, that is when, you know, we've determined that, okay, this is a good point to say that our patient is probably ready to exhale. So once it reaches that 25%, they'll exhale. Now, this can vary from breath to breath. So you might end up with breaths that are not the same length. And again, we can change this expiratory percentage between 5 and 60%. So if we were to set it to 60%, the patient would go into exhalation, you know, up here. So the patient wouldn't get to hold their breath very long at all. So like I just mentioned, because of the patient-driven nature of this ventilation mode, you might end up with breaths that are not the same length as the other breaths, which, you know what, that's how it is in their waking breathing habits. And you know, one of the goals a lot of times in anesthesia is to keep the patient as close to their normal waking vitals as possible. However, we do have this minimum respiration rate that can back us up in case that patient decides that they don't want to breathe anymore. And then the apnea ventilation will kick on and provide some mandatory breaths. So benefits and drawbacks of our pressure supported ventilation. Your patient gets to control the rate of breathing as well as the inspiratory time and flow. So your patient is getting to breathe spontaneously. They're getting to breathe at whatever rate they want to. They don't have to be captured by the ventilator. When we compare supported breaths to unsupported spontaneous breaths, this patient will end up with a lower respiration rate and a higher tidal volume. It reduces their work of respiration, and they end up with a lower O2 consumption and O2 requirement, because just metabolically they're a bit more relaxed. They're able to take great breaths every time. It helps to facilitate weaning because your patients aren't captured in the first place. You didn't have to drive down their respiratory drive just to put them on the ventilator. And it is quote unquote preferred by patients over more traditional modes, meaning your patient isn't fighting the ventilator as much. They can breathe much more easily. It's much more comfortable for them. One of the drawbacks, though, you do end up with a variable tidal volume and exhaled volume. So if you are trying to reach a certain tidal volume, just to maintain your patient's compliance, pressure support might not be the best choice. If the rise time to that pressure limit can't be adjusted, you may end up with some asynchrony. So if your T slope is not appropriate for your patient, they may end up breathing outside the ventilator. They might end up breathing out before they're ready to, or they might try to continue to inhale after you've reached after that T slope period. And then for patients with obstructive disorders, flow cycling to end inspiration might create some difficulty because they're not able to exhale as efficiently. And so that exhalation phase might be prolonged. So synchronized intermittent mandatory ventilation. So this one was actually in group 2 with a spontaneous trigger and a mandatory cycle. So this is supported breathing also, but it's good for patients that are taking spontaneous breaths, but they're not taking good spontaneous breaths. So SINV works with there's kind of 2 phases. You have a trigger period and a spontaneous period. So I'll kind of try to break it down for you a little bit better here. So each SIMV cycle consists of a trigger period and a spontaneous period. So your trigger window is determined as a certain percentage of an entire SIMV cycle, which is going to be determined by your respiratory rate. So essentially what happens is if your patient takes a breath during this period, actually, let me rephrase that. There will be a mandatory breath given at the end of this trigger period, no matter what. If your patient takes a breath right before that mandatory breath is given, the machine will go, oh, you know what? I was about to give a breath in half a second, but if you're breathing now, I'll go ahead and just give you this breath now. And I'll make sure that it's a good one. I'll support you. I'll give you a good breath. So if your patient takes a breath right when the machine's about to give one, it will support that breath to reach whatever mandatory breath settings were going to be given. So our delta P support, let's say that this is actually 10 centimeters of water. So let's say my patient took a breath right before I was about to get a mandatory breath. So the machine goes, oh, you know what? I'm gonna just move this breath up half a second sooner. But I'm going to make sure that you do get an inspiratory pressure of 15 centimeters of water. After they've exhaled, any spontaneous breaths that your patient may take over the next, few seconds, they're actually, your patient's not going to be fighting the ventilator. The ventilator will actually support those breaths. And that is where this delta P supplemental comes in. So like I said, let's say that this is 10 instead. So if your patient takes a little breath here, we'll have a little delta 10 centimeters of water. So your patient, as they take spontaneous breaths, it's going to be okay. We're going to be supported here. So versus our regular pressure control ventilation, if your patient were to take a breath outside of a mandatory outside of the mandatory breath, it would be fighting hard against the ventilator because the ventilator doesn't want to give a breath at that time. So they end up, kind of bucking around the ventilator. They end up kind of struggling to take another breath. So SIMV PC has kind of solved that. It's still going to deliver all of those mandatory breaths at that set rate, all of these breaths at this set rate. But if somebody takes a breath outside of that, those mandatory breaths, we're going to support those breaths. And that's why it's good for your patients with weak spontaneous breathing. This is just another, image of that. So we have our mandatory breath right here. And then in the spontaneous period, if your patient wants to take breaths, absolutely. So again, right here, if my patient isn't breathing during that SIMV period, they'll get a mandatory breath. But if they do want to take a breath during that SIMV period, the machine is going to support that breath, but make it the settings that we have for the mandatory breaths. I hope that makes sense, because I have another visual from a YouTube video that I found very helpful. And once I saw this illustration, I was like, oh, this makes sense now. So here we're talking about pressure supported breaths, but it's the same with volume supported breaths or volume control. So that's where the SIMV PC versus SIMV VC comes in. So we have our mandatory breaths like usual. And you can see where our spontaneous breaths are in the middle. They're not being supported. The patient is fighting against the ventilator. And then if that patient takes its own breath when it's about to receive one, in our regular mandatory ventilation modes, the ventilator doesn't care. The ventilator is going to give that whole breath on top of what the patient is already trying to do. And we've, that's happened to me so many times where my patient, isn't fully captured on the ventilator yet. And I see them taking their own big, nice, full breath. And then the ventilator gives them a big old one on top of it. And I'm like, oh, Lord have mercy. Did I just blow out my patient's lungs? I hope not. I wish I had SIMV at that time, because in between these mandatory breaths, if the patient takes a breath, we're going to support it. We're going to make sure that these are nice breaths. And if my patient were to take their own breath right when the machine was about to give one, it goes, you know what? I want to help you. I'm going to give you this nice, big, better breath so that it has the same airway pressure and the same tidal volume as the one that I was going to give you. I'm not just going to give you this nice little supported breath. I'm going to make sure that it matches those mandatory breaths, the dimensions of those mandatory breaths that we were getting. Once I saw this particular image, that was what really made a lot more sense to me for SIMV. And then lastly, we have ventilation support, which is actually volume support. I made a mistake on that. So volume support is patient triggered and patient cycled. So again, it's similar to pressure support, but this one's volume instead. So this is actually only found on the Vita 5, and it's actually on the Vita 5 basic model. So this is an intelligent ventilation mode that comes standard, which I feel like makes it considerably more accessible to people who maybe aren't comfortable with those rigid, volume control or rigid pressure control. So on the Vita 5, you can set a weight and it'll automatically calculate a tidal volume for you. Now you can change it in the settings, but it comes from the factory with a 10 mil per kg tidal volume. As we know, that range is 8 to 15 mils per kg. So 10 is a nice, somewhat conservative number, and you can adjust it if you have to. So if I were to set this to 40 kilograms and it populates a 400 mil tidal volume, but my 40-kilogram patient's ideal body weight is 25 kilograms, I can still go ahead, I can come in here and I can dial down that tidal volume that we're going to be trying to reach. So what VS does is the ventilator, when your patient takes a spontaneous breath, the ventilator is going to apply as low as supplemental airway pressure as possible during that inhalation phase to try to reach this goal tidal volume, this set tidal volume. With every breath that the patient takes, the ventilator will automatically recalculate and reevaluate what did our tidal volume look like on this last breath. Okay, let's go up by 1 centimeter of water for the next breath, and see if we reach our goal tidal volume on this next one. And then fortunately, we still have this minimum respiration rate. So if your patient doesn't trigger an inspiration, that's in fitting with a respiration rate of 20, or for a bigger dog, 6 or 4, the system will turn on backup ventilation and it'll provide volume controlled breaths at this goal tidal volume. So, if your patient suddenly decides that they don't want to breathe, it's okay. They're still going to get ventilated in accordance with this minimum respiration rate that you are able to set yourself. So here's our little waveforms again. You can see that this is kind of a little more similar to our volume waveforms, because it's a slightly, slower inspiratory time. Of course, that's still determined by the patient. So we have our trigger right here, which can be either auto or you can set it yourself. It will actually kind of automatically adjust as well if your patient has a respiration rate above 20 and their inspiratory flow is very low. They're taking these puny little shallow breaths. The trigger will start to learn that, okay, this patient is taking very poor breaths at a high rate. I'm only going to support the breaths that have that are making a real effort. So it'll adjust the flow, the flow requirements or the pressure requirements to be less and less sensitive so as not to hyperventilate your patient. Because if your patient is taking 22 breaths per minute and they are very puny, poor breaths, we don't want to be supporting every single one of those, because then your patient's going to be hyperventilated. We only want to support the good breaths, right? So we can see here our airway pressure, our pressure support is starting out low to try to reach our ideal tidal volume through here. Again, we have our automatic expiratory phase once your patient is no longer breathing in. And with each subsequent breath, we're seeing, a little bit more supplemental airway pressure, trying to reach this tidal volume that we've set for ourselves. Now, if the patient were to go apneic, there we go. We kick on some apnea ventilation. It'll supply some a mandatory breath, and then the timer resets until, hey, is this patient going to take a breath in time? If not, here we go. We're going to kick on another breath there. So there we go. This one is only available on the Vita 5. So, the Vita 5 being more streamlined, a little bit more resembling a normal veterinary anesthesia machine. This ventilation support mode right here, it takes out the necessity of capturing your patient. So part of the worst part of putting a patient on a ventilator is, kind of messing with it and fiddling with it to get them to stop trying to breathe around the ventilator. In this case, we want them to breathe on their own. And the ventilator just helps them take better breaths. And then when it comes time to wake up the patient, hey, they've been breathing on their own this whole time. They've had a respiratory drive this whole time. So you don't even have to wean them off the ventilator. You just turn off the ventilator and they're still breathing on their own. So it's very simplified as compared, obviously it's simplified compared to these, but you know, that's the whole point. If we take away some of these and just kind of automate a few of these to make it less scary, that's a whole lot more people that are going to adopt ventilator use in their patients. And you know, every single human who goes under anesthesia goes on a ventilator. Why not, you know, why not animals? So there you go. I'm all done with my portion. If you have any questions, put them in the chat box or the Q&A feature there. But if you don't have any questions, thank you so much for joining us. These are my pets. They're very cute. Yes. They just lay on their backs all the time, looking cute. Warren, did you have anything else to add?
No. Does anyone has any question? Thank you, Lindsay.
Thank you,
For
Warren.
your sharing, and your pet is very cute.
Oh, thank you. Thank you.
Oh,
It's so obvious.
Okay. Does anyone has any question?
All right, well, it looks like nobody has any other questions, but if you think of something later, I think Warren has provided his email address to use or to send questions. And he'll be able to answer your questions better than I'll be able to answer yours. So please direct all questions to Warren.
Yeah, if you have any question, you can contact me through my email. Okay, so if no one has any question, thanks for your time. Thank you, Lindsay. Okay, that's today's sharing.
Thank you. Thank you for having me. Right. CK, yeah, sure.
Yes, we will send the video to our sales, and you can get the video from them. Okay, goodbye, everyone. Goodbye, Lindsay.
Bye, everyone. Have a good day wherever you are, or a good night wherever you are.
Bye.